Welcome to today's case discussion number 1 on acute cholecystitis. This is a clinical summary of the patient. He's a 67-year-old fisherman who presents with a sudden onset of severe right hypochondrial pain for 5 days. It was localized to the right upper quadrant with no radiation elsewhere. It was associated with nausea and vomiting for the last 2 days, and he admits having similar but milder pain off and on 2 occasions before, for which he took some painkillers to relieve the pain. There's no history of fever, no diarrhea, and no urinary symptoms. He is a diabetic for the last 10 years and on treatment. On examination, he is afebrile with no pallor or jaundice. There is tenderness and guarding in the right upper quadrant, and Murphy sign is negative. The liver and spleen were not palpable, and rest of the abdomen is normal. Now we come to the analysis of the symptoms and signs in the patient. Okay, these are the symptoms: severe right upper quadrant pain for 5 days. He's an elderly man, 67 years old, associated with vomiting and similar episodes twice in the last 2 months. He's a diabetic. Examination: there's tenderness in the right upper quadrant with guarding, Murphy sign negative, and he is afebrile. So with these clinical symptoms and signs, the provisional diagnosis would be acute cholecystitis due to gallstone. The differential diagnosis would be acute gastritis, perforated peptic ulcer, acute pancreatitis, and cholelithiasis with cholangitis. Now, the investigations for these patients include blood tests, urine, imaging, and biopsy, special tests for the patient, and others may be necessary. Okay. In the blood investigations, important things to be done are the full blood count, the renal profile, liver function, and other tests. Okay, under the full blood count, the most important is your total white count, which is elevated. Under the renal function test, all the results are normal, and liver function test is essentially normal except for elevated aspartate amylase, okay, which is elevated. The blood glucose is also elevated, greatly elevated to 27 millimoles per liter. And it is important to do the blood culture and sensitivity on admission. Okay, these are all showing the elevated parameters.
Okay, this slide shows you the various imaging that are used in the diagnosis of acute cholecystitis. Okay, first we have the common or the must-do investigations, which include a plain X-ray, including chest X-ray and abdominal X-ray, and an ultrasound abdomen scan. Okay, these two are considered mandatory. And then the others will be those who are done as required by the individual patient. This includes a CT scan, MRI scan, and ERCP.
Okay, next we come to chest X-ray. The use of chest X-ray in a patient with acute right hypochondrial pain, suggestive of acute cholecystitis. Chest X-ray can be used to exclude a number of other conditions that commonly occur in these patients. Okay, the first among them is a chest X-ray here showing you elevated right diaphragm, okay, which is a suggestive of a liver abscess in the right lobe of the liver. Secondly, you have got a consolidation of the lower lobe of the lung, right lung, which is due to right lower pneumonia. These two can be clearly seen in a chest X-ray. The third is free air under the right diaphragm, pneumoperitoneum, which usually occurs in patients with perforated peptic ulcer. Okay, so these are the three common conditions that must be excluded in patients who come features suggestive of acute cholecystitis. Okay, this is an ultrasound of a gallbladder, a normal gallbladder with a thin wall and empty lumen. The lumen is empty, there's no stones, and the wall is very thin, less than 3 millimeters in thickness. The gallbladder is 7 to 8 centimeters in length, 3 to 4 centimeters in transverse diameter. Over here is another ultrasound showing you the gallbladder here. This time there are hyperechogenic shadows within the lumen of the gallbladder, which are gallstones as revealed by the posterior shadow that they cast in on ultrasound. The gallbladder here is thickened. Areas of the wall is thickened more than 2 millimeters, and also there is pericholecystic fluid, which are features of acute cholecystitis. This is an ultrasound picture of a gallbladder in patient with acute cholecystitis. So the changes are presence of gallstones, which produce posterior shadow, a thickened gallbladder, which should be more than 3 millimeters in diameter, and also pericholecystic fluid, edema fluid around the gallbladder. Okay, so these are the changes that occur in a patient with acute cholecystitis: stone, thickened gallbladder wall, pericholecystic fluid. Okay, this is another few pictures to show you the ultrasound of the gallbladder. There's a stone here, but the gallbladder wall is not thickened and no evidence of pericholecystic fluid. So this is either an asymptomatic gallbladder, gallstone, or biliary colic. This one, a gallbladder with multiple stones, casting posterior shadow here. So this is a normal gallbladder, a gallbladder with a stone in the neck of the gallbladder. CT scans at times may be necessary in cases like this, where it shows the gallbladder here, which looks quite normal. Whereas here, the gallbladder is dilated, thickened with stones in the neck of the gallbladder. Okay, what are the complications of acute cholecystitis? First, empyema of the gallbladder, where the formation of pus within the gallbladder due to cystic duct obstruction or gallbladder outlet obstructions at the Hartmann's pouch. Perforation of the gallbladder with bile peritonitis is another serious complication of acute cholecystitis. Sepsis and septicemia related to empyema of the gallbladder, and repeated attacks leading to chronic cholecystitis. Now we come to the management of gallstone cholecystitis. Okay, first confirm the diagnosis, and this can be done by ultrasound of the abdomen. Then continue with initial treatment or resuscitations with IV fluids, electrolytes, antibiotics, analgesics, and if the patient shows signs of septicemia or infection, which is not there in this patient, you may have to admit the patient with ICU and give oxygen. In the process, you do a close monitoring of the patient, BP, blood pressure, pulse rate, and oxygen saturation, and urine output. When the patient is stabilized with all these initial treatment, then you proceed with the definitive treatment. So in this case, first is medical treatment, which consists of analgesics and antibiotics. And the antibiotics normally given for these conditions, gallstone acute cholecystitis, will be cephalosporin with or plus or minus metronidazole. Then endoscopic treatment can be done, especially if there's a stone in the gallbladder bile duct. then a endoscopic sphincterotomy may be needed. In this patient, that is not necessary, so we go on to surgery. Okay, so these patients need surgery. They need cholecystectomy, which can be either open or laparoscopic. Okay, so here summary of the treatment: initially conservative, followed by cholecystectomy. So these are all the conservative treatment. Cholecystectomy preferably done within the first 2 days if necessary. If the patient shows signs of worsening or signs of infection, sepsis, or if the patient improves, then antibiotics is continued until the patient recovers fully, and elective cholecystectomy will be done after 6 weeks. So initially conservative treatment followed by elective cholecystectomy is the treatment of choice. Unless the patient becomes more ill within the first 2 to 3 days, then an emergency cholecystectomy may have to be done.
Now we come to some questions on this topic of acute cholecystitis. As you read the question, please pause the video, answer the question, and resume the video for the answers. Question number 1. Whose sign is elicited on the examination of the abdomen? The answer, Murphy's sign. Question number 2. What is the most likely diagnosis in this patient? The answer, acute biliary colic or acute cholecystitis due to gallstones. Question number 3. What is the treatment for the patient? Answer, IV fluids, analgesics and antibiotics are the initial treatment, followed by surgery, cholecystectomy, either laparoscopic or open. Question number 4. What would you prescribe to treat the high blood glucose in this patient? The answer, IV insulin titration against the blood glucose. Question 5. What specific complications in this patient is this patient at risk of? Answer, empyema of the gallbladder, gangrene, perforation and septicemia. Thank you for joining me for this session. Hope to see you again in another session in the near future. Thank you.